Emergency departments in healthcare organizations can be parallel to the liver organ in the human body. When the liver is operating healthily and efficiently, it allows the rest of the body to function properly. When the liver is not running optimally, the rest of the body suffers along with it. In similar fashion, when the emergency department is not running optimally, the implications for the rest of the medical center are significant. A poorly operating ED with long waiting times increases stress levels of employees, increases use of resources, and increases the financial burden on other departments in the medical center. Kaiser Permanente South Bay Medical Center's emergency department faces crowding, long wait times, and is among the larger financial burdens on the organization. This ED is one of the poorest performing EDs among KP medical centers in Southern California region. South Bay ranks 10th, 12th, 13th, and 13th, respectively, out of 14 medical centers in Southern California in the following metrics: length of stay for admits, left without being seen %, length of stay for ESI 4 and 5, and arrival to room times. These metrics are all indicators of patient satisfaction and efficiency, and KP South Bay's ED has significant room for improvement in these areas. Unlike in fee-for-service medical centers where providers may financially benefit from increased patient length of stay and admissions, South Bay performs worse when the ED keeps patients in beds instead of discharging them. The long wait times and volume of low acuity patients in the ED at KP South Bay place a burden on other patients and resources. These burdens are a result of KP's inefficiency, and unless improvements are made, the ED at South Bay will continue to perform among the poorest EDs in the Southern California region. According to the Agency for Healthcare Research and Quality, variation leads to inefficiency in emergency departments. Variation is associated with inefficiency because variation doesn't allow task completers to follow a standardized process. When the Industrial Revolution occurred in the 1800s and business owners needed to think of creative production practices to outdo the competition, the assembly line was birthed. It took one worker much too long to make an entire widget. But give that employee a single task, and as a group, the factory could pump out more widgets than if each employee built his own from start to finish. Healthcare is much more complex than building widgets, and duties can't be standardized on a task basis when dealing with ill patients, but there is room for improving variation in healthcare, especially in the emergency department. The concept of standardization can be applied to emergency departments too, where patients are triaged according to severity of condition. The Emergency Severity Index is a numeric coding system used to triage patients according to severity of complaint and resources needed for the complaint. ESI runs on a 1 to 5 scale, with 5 being the lowest acuity and lowest resource intensive, while 1 is high acuity and high resource utilization. Typically, EDs with crowding have a higher volume of low acuity complaints, and this is definitely the case at South Bay. A number of studies and books document what is known as the split flow workflow used in emergency departments across the country. The purpose of the model is to separate patients of low acuity and high acuity into separate workflows and physical spaces. The emphasis of the split flow model is on customizing a separate workflow for low and high acuity patients, which will help improve throughput. The idea is that if low acuity patients are organized into separate streams, it will improve efficiency in discharging those patients while simultaneously not occupying resources needed to treat patients with more severe complaints. A key component of the split flow model is limited variability in patient needs on the low acuity side. The Medical Group Administration at KP South Bay has decided to pilot the implementation of a split flow model to see if it improves ED performance. An analysis of before and after performance in the key ED metrics, length of stay for admits, left without being seen %, length of stay for ESI 4 and 5, and arrival to room times, will allow us to determine if the split flow workflow was effective and whether it should be replicated in other emergency departments. In looking at the post-split flow implementation metrics, the data confirm that KP South Bay improved their ranking across the board for each of the 4 key metrics. KP South Bay saw significant improvements for arrival to room times, in which it jumped from 13th in the region to 4th in the region. Left without being seen % also improved from 13th in the region to 9th. These improvements indicate that in the short term, the split flow model has been effective. Continued evaluation of metrics and small tweaks to the process can be documented over the long term, and these recommendations can be provided to other medical centers facing similar issues. Thank you.